I'll give an introduction to Dr. Baird. He's also called Lieutenant. Lieutenant John Baird is an officer in the Commissioned Corps of the U.S. Public Health Service. He is currently assigned to the CDC's Epidemic Intelligence Service and stationed at the National Institute of Occupational Safety and Health. His current work includes exposure and epidemiological studies of carbon nanotube workers and occupational risk measures for neurological diseases. In 2015, Lieutenant Baird was sent to the Dominican Republic to investigate and stop an outbreak of histoplasmosis among tunnel cleaning workers. That's an interesting story. Maybe or maybe not, he'll share that one with us today. But if not, you can check with him later on that one. Prior to joining the Commissioned Corps, Lieutenant Baird was a pre-doctoral fellow at the National Institute of Environmental Health Sciences and an environmental epidemiologist at the Utah Department of Health. Dr. Baird is an alumnus of Brigham Young in our MPH program, as well as in the statistics department here, and he has a PhD from University of North Carolina in Chapel Hill. And so we're really glad to have him with us. The faculty have been chatting with him throughout the morning, and it's a pleasure to have him. And so, since he's a lieutenant, why didn't everybody raise your hand like this? And let's do one of these to welcome.
I'm going to stop spoken. Move it up. Yeah. Is that better? Okay. So thank you for having me here. Very excited to come back to BYU. It's always a privilege to come back to the flagship, as we say. So today we're going to walk through a mock cluster investigation. And the setup here is that there is a cluster of amyotrophic lateral sclerosis, which is a neurodegenerative disease, and it is among Gulf War veterans at Hill Air Force Base in Ogden, up by Ogden. So who here can tell me what a cluster is? Okay, so a cluster is an excess of disease in time and space. So in this case, we're going to say that this cluster has occurred over the last 5 years, from 2012 to 2017. So we have an excess of ALS. And normally you would be looking at a geographic location, so we would say at Hill Air Force Base. However, with military veterans, because this is a chronic disease, it's going to take some time to develop. We're going to assume that it's actually something that happened in the Gulf when they were at war in the Gulf 25 years ago. So we're going to assume it's not something that happened at Hill. So has anybody ever heard of ALS? Does anybody know what that is? Do you want to go ahead, DK?
Oh, I've heard of it.
Okay. So it's a neurodegenerative disease that affects the motor neurons. These are the neurons you use to move your muscles, to speak, to swallow. So they're pretty important neurons. So we're going to pretend that everybody here works for a local, state, or a federal agency. So local health department, state health department, or the Department of Defense, or DOD, the Department of Veterans Affairs, or VA, or the Centers for Disease Control and Prevention, or CDC. So you are assigned to investigate the cluster and to identify the cause. Before we do that, though, I'm going to give a little bit of background so we have something to work with. So on August 2nd, 1990, Iraq invaded Kuwait basically for 3 reasons. One was kind of a border dispute, like where the boundaries should be. One was over money, and one was over oil. So Kuwait is in the yellow, and Iraq is right next to it. So they deployed 100,000 soldiers from Iraq to Kuwait, and they took over the country in 1 day. some of the royal family from Kuwait escaped to Saudi Arabia, where they then appealed to the United Nations Security Council for help. And the UN formed a coalition of several countries that were willing to help, including the US. So 5 months later, the coalition deployed troops to the Gulf to begin to try to drive the Iraqis out. And it was, of course, all over the news. So the size of how big we're talking about, as I mentioned, Iraq deployed 100,000 troops, and the coalition deployed 950,000 troops, so 9.5 times the number of Iraqis there. And the U.S. supplied 700,000 of those troops. Anybody here have a relative or a family member or a friend who served in the Gulf War? Okay, several. All right, well, thank you for your service, for their service. So these 700,000 troops, it was out of 2.5 million troops that were available to the U.S. at that time. So this works out to 2 of 7. 2 of every 7 troops in the U.S. at that time were deployed to the Gulf. So this was 28%. That's a pretty huge military operation for the U.S. to be involved in. So when the troops were in the Gulf, they were exposed to a lot of different things. So in the upper left here, we have oil well fire smoke. So this is an oil field. The Iraqis were setting Kuwait oil wells on fire, and it's creating huge amounts of black smoke, as you can see there, and the soldiers are relatively close. I even saw a picture that had a bunch of fires and some camels in front. So this is affecting animals as well as humans. This is the desert, so on the bottom right here, this is showing as we have our tanks and our soldiers and all this stuff in the desert, we're generating lots of dust and sand, so respiratory exposures are potentially a problem. They're exposed to Scud missiles and depleted uranium. So on the left, this is an Iraqi Scud missile launcher. They actually fired Scud missiles among other places on Israel and against coalition forces. So lots of explosions, a high-stress environment, in addition to whatever fallout you're going to have from that. And then depleted uranium. So this is ammunition over on the right. So people were actually using radioactive material as ammunition and shooting it at each other. So that seems pretty problematic in terms of health effects, right? So this picture on the left, Iraq had chemical weapons such as sarin, which you've probably heard in the news recently with Syria. So sarin is a nerve agent. It's an organophosphate compound, so it's similar to the way some insecticides work by affecting the nervous system. And so you can tell with these soldiers that not only do they have full face respirators, but they're covered head to toe. Even their hands are covered, their faces are covered so that they are not exposed to this nerve agent. Coalition forces set up chemical alarms all around the Gulf, and they were supposed to detect the nerve agents before the soldiers got to them. And then when they went off, they were supposed to take these pyridostigmine bromide, or PB pills, which are up on the right, little white pills. And this was supposed to kind of prevent sarin from binding to the neurons, and so therefore prevent the effects of it. However, there's some anecdotal evidence that the chemical alarm sounds were too sensitive, and so they were taking these PB pills too frequently, and that may have caused some issues. In clinical practice, PB pills are used to treat a neurologic condition called myasthenia gravis. So down here on the right, so this is in a desert area with lots of mosquitoes and other bugs, and so they have their uniforms down here on the ground, and they are spraying permethrin, which is an insecticide, onto the uniforms. And there is also some anecdotal evidence that they were treating their uniforms too often. They should have been treating them, say, every 6 weeks, and they were treating them like weekly or something like that. So their exposure to this insecticide and these uniforms that they're wearing around could have been a lot higher. Because you were deploying troops to places in the world where they're not from, infectious diseases are of course a concern. And so they got all kinds of vaccines, which is what's shown up here in the right. And of course there were also concerns about potential biological weapons, such as anthrax. So this is an overview of some of the things that they were exposed to besides gunshots and things like that when they were there. So fighting lasted for 6 weeks, and then the coalition troops drove the Iraqi forces out of Kuwait. However, the effects of the war on the soldiers did not end at this time. When pretty much immediately when all these soldiers came back from Kuwait, they started complaining of various health symptoms, rashes, respiratory illnesses, neurologic, gastrointestinal, and none of it was like a specific disease. And it's been hotly debated in the literature. They've since dubbed it Gulf War illness, but it's kind of this multi-symptom disease. A specific disease, and maybe the only specific disease that they have linked to service in the Gulf potentially though, is ALS. They did some studies in 2003, so about 10 years of follow-up, showing that vets who went to the Gulf were at about twice the risk of ALS as vets who were deployed to other parts in the world at that time. And then 2 years later, another study was published that showed any veteran was at about a 50% increased risk of ALS compared to non-veterans. So you may have heard of ALS from the Ice Bucket Challenge a couple of years ago. Did anybody participate in that? Yeah, got like a cool YouTube video or something? So, some famous people with ALS. Does anybody know who this person on the left is? Gary, yeah. So he's the famous New York Yankees first baseman, the Iron Man. He played like 2,000 games in a row. And he was really the first person, the first famous person that had ALS, and it was really the first time that ALS came to the public limelight, that people became aware of this disease, even though it had been discovered in like the 1840s or something like that. How about this person on the right? Stephen Hawking, yeah, the famous theoretical astrophysicist. So as I mentioned, ALS is a neurodegenerative disease that affects your motor neurons. So on the figure here on the left, you have two types of motor neurons. You have your upper motor neurons, and these are in the cerebral cortex up in the top of your brain. And then you have your lower motor neurons in your brainstem and your spinal cord. The upper motor neurons innervate the lower motor neurons, and the lower motor neurons in the brainstem are the ones responsible for speaking, swallowing, control of your facial muscles. Whereas the motor neurons in your spinal cord are responsible for moving your limbs, your fingers, and even for respiratory, for breathing. So in this figure over here on the right, on the left you can see a normal, these are spinal motor neurons, a normal fiber looks nice and robust, it's connected to the muscle down here, the muscle is nice and strong. And on the right you have an ALS or a diseased motor neuron, so it's, see it's kind of atrophying and decaying. There's a lot of neurofilament buildup, and it's starting to pull away from the muscle, and the muscle is atrophying and shrinking. So as you can guess, symptoms with that figure, symptoms that these people have are muscle spasticity, difficulty speaking or swallowing. They start drooling excessively. They have difficulty combing their hair because they can't either get their arm up there or they can't hold on to the comb, tripping, and eventual paralysis. Unfortunately, ALS is extremely progressive, extremely aggressive, and half of people die within 3 years of diagnosis. Only about 5% survive at least 10 years. So Stephen Hawking having it for 50 years is really unusual. Thankfully, ALS is really rare. Incidence is only 2 per 100,000 per year. And most people who are diagnosed, 90-95%, do not have a family history. So this suggests that the environment or gene-environment interaction could be playing an important role in the etiology of ALS. Established risk factors are increasing age, male gender, and cigarette smoking, although some studies suggest that cigarette smoking is only a risk factor among women. Lots of other things have been studied, including several occupational environmental exposures, but most of the literature is pretty mixed. So these are really the only ones that that are agreed upon that would be risk factors. Okay, so with this background, let's come back to our cluster investigation. So again, we work for a local, state, or a federal agency, and we're assigned to investigate this cluster and identify the cause. So we're going to walk through this mock cluster investigation, and then I'm going to tell you what actually happened. So what is the first thing that we need to do in a cluster investigation?
Can you identify what symptoms there are and what potential diseases?
Okay, so what is it? So kind of verifying what the disease is, okay? Any other ones? Yeah.
Maybe identifying like what environmental exposures they had in common.
Okay. Right. Any other ideas?
Identify your cluster.
Okay, confirm that it is a cluster, and where is it? So the very first thing that I actually think we should do is identify our team. Who do we want on our team to help us investigate this cluster? So who here is in the environmental and occupational health emphasis? Okay, one, is that it? Couple, okay. All right, so what can, and this can be for anybody to answer, so what would somebody in the environmental occupational health emphasis, what would they bring to the team in investigating this cluster of ALS among military veterans?
I'm taking an occupational safety and health course, and we talk a lot about chemical exposures, and so that just kind of brings a knowledge of like types of chemicals that would like cause adverse effects, just to be like within our team.
Yeah, so like the comment over here, trying to identify what the exposures are. I also think that they would be familiar with data sources and methods of how to assess exposure, right? Okay, so who here is in the epidemiology track? Okay, great. So again, for anybody, what would an epidemiologist bring to this cluster investigation? Statistics, yeah. You're going to get some data, so data management, data collection, connecting exposure to disease, and doing lots of statistics. Okay, so who here is in the health science, like preclinical emphasis? Okay, so a lot. What would a preclinical, or like what would a clinician, a physician, or a dentist, or a vet, like what would they bring to this cluster investigation?
Maybe like just knowledge about the signs and symptoms and the pathophysiology of what all these people are experiencing.
Yeah, so we had the comment earlier about verifying this is actually ALS, and so that's exactly right. What data sources would they have knowledge of to help us to verify that diagnosis? Like how could you verify the diagnosis? So you could okay, yeah, like,
Maybe from information taken from hospitals or different areas, just
Yeah.
sort of comparing the symptoms.
So yeah, medical record review would be a way to do that. Okay, so then, actually, sorry, I was gonna, so we're right here on team, and we're gonna walk through each of these sections together. Okay, so then who here is in the health promotion track? Okay, so what would a health promotion person bring to this investigation? Okay, yeah, that there is a cluster, so they're going to be helpful in verifying. And so one of the things you're looking for additional cases, they could help to publicize it. What else?
So a lot of emphasis on communication between different teams, organizations, and to the public as well.
Yeah, yeah, exactly. If this is a cluster among veterans, it's probably going to get some media attention. So having somebody who knows how to communicate in layman's terms is going to be really helpful. I think health promotion would be really helpful in designing your questionnaire. Again, trying to get those terms in layman's terms. If you're not aware of what the exposures are, you could do focus groups, and they could be very helpful there to try to generate hypotheses about what exposures are. So I think health promotion, even though we don't necessarily think of them as somebody involved in a cluster investigation, could be a really important team member. Okay, who here has taken the medical geography class that Dr. Sloan teaches, like GIS? Okay, way in the back. Great. So what could like a GIS person bring to a cluster investigation?
They can help make a map to see where the exposures are and how it's related.
Yeah. So we talked about a cluster being something in time and space, right? An excess of disease in time and space. So they can map the disease, so just like John Snow with the cholera outbreak, for example, or like this study. So this is a study where some researchers at Duke University, they were able to get information from the Department of Defense, and they got information on where every person with ALS and every person without ALS was deployed when they were in the Gulf, so they know where their squad or their unit was. On the left here, this is where they mapped the locations of all of the non-ALS cases. You can see they're kind of all over. And on the right, they mapped where the ALS cases were, and you can see they're mostly clustered up there in the Gulf area. took this a step further and used Bayesian statistical methods to map the spatial risk of getting ALS based on where you were deployed to in the goal. So the darker colors represents higher risk. And there in the middle, they identified a location where that had the highest estimated probability of getting ALS based on spatial risk. And this location is about 500 kilometers or about 160 miles to the southeast of Tunisia, which is denoted with that pentagon there. And this is important because I noted that Iraq had nerve agents, and chemical weapons. Well, most of those were located in Tunisia. The U.S. did not know that, and they blew this place up, which then created a plume cloud of nerve agents, and that went over about an estimated 100,000 U.S. troops. And so this location kind of fits that story. So it's really kind of a provocative and an interesting study, an example of a value that GIS and medical geography can bring to the cluster investigation. So there's one more type of person I want to talk about in terms of the team. Why would it be important to have an engineer on a cluster investigation team? Any ideas?
Well, going back to, you showed us earlier a picture of like all the gear and things that they had. An engineer could see like, was that actually effective? Like, was it working? Is there a way to improve it? So I don't know if engineers handle like clothing stuff, but
Yeah.
they could contribute to that.
So there are a lot of different kinds of engineers, and for example, like I showed earlier them spraying the pesticides on the uniform just on the ground. Well, there are different kind of nozzles you can use on your spray gun. Some nozzles are going to create a lot more spray, therefore a lot more exposure, and other nozzles are going to have be a lot more contained and make a smaller spray. Yeah, go ahead.
Another thing that a lot of engineers do, I'm sure, is like a lot of weapons, and like they know probably how those work. A lot of them might know like maybe if those type of things might give different exposures, blah blah blah.
Right. Yeah. Another example I thought of was, so if this was more like in a kind of your classic occupational setting, so you're in a manufacturing facility or something like that, a lot of those facilities have like ventilation to help kind of exhaust the product or the byproducts of whatever they're manufacturing to the outside. So an engineer is really helpful to do like a ventilation assessment or any kind of mechanical assessment. They can come in and see it, is it actually working, and if not, how can you fix it? So, all right, so we talked about who's on our team. Now let's talk about objectives. So what's kind of the goal of our investigation? Yeah.
Figure out what's causing the ALS and prevent it.
Yeah, right, exactly. And then, as Dr. Thackeray mentioned later, maybe confirming the cluster. For today, we're going to assume that the cluster's already been confirmed, and we're going to go with the objective that you talked about. Let's figure out what caused this thing. Okay, so for this next section, we're going to break up a little bit. We're going to break up into 4 sections. You're just going to talk to the person, like 2 or 3 people, talk to the person next to you. This section, I want you to talk about what kind of study design should we use for this cluster investigation, and I'll give you like a minute to do that. This middle section, we need to talk about how are we going to assess ALS. We've already kind of talked a little bit about this, but what are the data sources? How should we go verify that these people have ALS? This next group, let's talk about exposure assessment. How can we assess exposure? And we're going to do data collection and analysis all together. And so then this last group, I want you to talk about recommendations. So if we identify chemical X that seems to be associated with ALS in this cluster, what are we going to do about it? What's our recommendation to the Department of Defense to stop this from happening again? So everybody take a minute, and if you're in your 4th section, just talk to the next groups of 2 or 3, and then we'll come back together and talk about study design.
We've got
Small amount of
Okay, so let's come back together now. So for this section, what kind of study design do you think we should use for this investigation? Or anybody can answer.
Dr.
that.
Novelia said case control.
Okay. What were you
We
thinking?
talked about just like a retroactive kind of qualitative
Okay.
get interviews and just ask them what they were exposed to, what they're exposed to.
Okay. So what are the advantages of a case control study versus say a cohort study in this setting? Anybody can answer that. So let's think about what we know about ALS. ALS is really rare. So in order to get enough cases in a prospective or in any kind of a cohort study, we're going to need a huge sample size. Where with a case control study, we start with our cases, we identify a representative sample of controls, so it's a lot easier to do. This is also in most large cohort studies, they're not designed to assess it to study ALS. So. And especially like military factors in ALS. So you're going to have limited exposure data, limited compounder data. Whereas in a case control study, you can get really rich, detailed exposure data about what they were doing, what they were exposed to, did they wear personal protective equipment, what kind, those sorts of things. Also, in these kind of public health, important in public health, getting an immediate response type of issues, the cohort studies are probably going to take too long. It's too expensive. So a case control study has a lot of flexibility, and I would say should be the design that we should go with in this investigation. Okay, so the section about assessing ALS. So how can we verify that they have ALS?
We were talking about getting some people together that have it, but we also have to be really fast about it because you said there's like a 3-year period to do that.
Yeah. Yeah. So you can certainly do in-person neurologic exams, and you could verify that way, and through EKGs and other things, other tests you can do to verify they have ALS. ALS is a very difficult disease to diagnose. It's basically a diagnosis you come upon by elimination, so nothing else explains it. Therefore it's this. Another option would be medical record review. As noted though, given the quick progression, I don't know that in-person exams is going to be possible, especially if we have deceased cases. So I would advocate for anybody who's alive, let's do an in-person exam if that's feasible. And otherwise, and in addition, let's collect the medical record data so we have a lot of clinical information and we know dates of onset and we have data for everybody. Yeah.
I have a question. In this case, would most, if not all, of the medical records be available through the VA medical system, or would you need to go into other health systems as well?
Yeah. So, so if they're still in the service, then all of their medical records should be available through the VA, unless they're seeing a private doctor. If they're out of the service, if they're no longer part of the military, then they could have private care. And so you could ask each of these cases for permission to request records from their doctors, and that would be the way that I would recommend doing it. Getting data from the VA that you can, and then requesting additional data from their private providers. Okay. So, all right, so exposure assessment. What are some ways that we can assess exposure to some of the things that we talked about earlier, like PP pills and things like that? Any ideas?
We talked about the cloud, the plume of what was it called?
The Sarin, the nerve agents?
Yeah. And looking at how far that might have reached and the troop activity at that time, and whether they were indoors or outdoors and stuff like that, and how much they might have been exposed to.
Okay. Any other, yeah.
I think with all of the exposures, maybe testing how much, like a dosage of these, or how much exposure would trigger a neurologic response.
Okay. So that would probably be animal studies, right? Yeah. Any other ideas? Okay, so there's actually a lot of ways that we could assess exposure. So coming off of your comment, military records might be an option. So with military records, you're going to know what branch of service they were in, you're going to know where they were located, and you're going to know when they were there. But will you know if they were exposed to a certain thing while they were there? Probably not. So it's not going to be very good for detailed exposure information, but it will be good for location and things like that. You can measure you can take their blood and urine and look for biomarkers or indicators that they were exposed. It's going to be, why do you think that would be challenging in this setting? Yeah, it's been 25 years. So you need a biomarker that has a half-life long enough that you're going to pick it up and then it's going to be replicated that you can back calculate to get that value. And that's probably not going to happen.
I have another question. Would some of these people have had blood samples taken during their military service that were stored and still available?
Yeah, some of them might. So there is a large biorepository of blood samples available for new military recruits. I don't know exactly how many people they've in that, but they've used that, for example, at Harvard they did a study of multiple sclerosis among these people in the military, and they were able to use their biorepository samples to look at exposure to Epstein-Barr, like antibodies. And it would demonstrate that people who were exposed to Epstein-Barr before age of 20 had a higher risk of MS compared to those who were exposed after. So you can certainly look for those biorepositories if they go back far enough for what you're interested in. Why would doing like personal air sampling, you know, having the soldiers wear pumps and filters, or why would that be challenging?
Because they're not in that area at that time anymore, like.
So kind of the same thing as before that. This is 25 years ago. That ship has sailed. Also, like, if you're in a combat zone and you're also wearing industrial hygiene equipment, it's just not really going to work. Because then we're interfering with their jobs at that point. And the last one I want to talk about is questionnaires or interviews. So what are the pros and cons of questionnaires and interviews?
I don't know if this is applicable, but I would think like thinking back, a lot of veterans have like PTSD. I don't know if like talking to them about it would be like a trigger things.
Right. Yeah. That's true. So you would definitely want to work with like psychologists, clinical psychologists, colleagues, to be sensitive to those types of issues, and that could be a challenge. So in this kind of retrospective recall, what kind of biases are we worried about?
Well, sometimes if you ask people like, well, how many times did you do this? There's just like such an inflation in number by the time it's been like 20 years. So like right when you get home, you might have been like, I did that twice. But then by the time it's been 20 years, you're like, oh, we did that dozens of times. Or like, you know what, we did that 1,000 times.
Yeah.
And so they're just like the numbers could mean nothing.
Yeah, so we're definitely concerned about information bias, right? Particularly if our cases seem to over-report certain things relative to controls, or they have a better memory because they're wondering why did I get this disease, so they've been thinking about it for longer. So given all the challenges, though, of biomarkers and personal monitoring and the limitations of military records, I think we should go with personal interviews in this situation. And I will note, too, that because ALS, a lot of them have difficulty speaking, you may need to talk to a caregiver or a proxy, and that brings its own set of challenges. Okay, so for this section, data question and analysis, I need 5 volunteers to come up to the front of the class. Okay, so come on up. I need 4 more. 4 students to come up, yeah. Okay, let's do 1 more. So we're interviewing people in our study. Some of these are cases, some of them are controls. It says on their envelope whether or not they're an ALS case or whether they're a control. And they're going to help us. We're going to cheat a little bit and skip data entry, and they're going to help us to do our analysis and figure out what these people are exposed to. So if you have a picture of the exposure, that means you're exposed. If you don't have a picture, that means you're not exposed. So there's 4 exposures here, and pay attention to what it says on the front if you're a case or a control. So if you're a case, I want you to go ahead and put your picture on the bar chart over cases. If you're a control, go ahead and put it over controls. So go ahead, you can put that up. Oh, sorry, I should have noted that I have tape over here. Creative, look at that. And I also have a tacky. Thanks, Kevin. Yeah, you guys can sit down. Okay. So looking at our 4 bar charts, which one of these exposures is likely associated with our development of our cluster? Yeah, the PB pills. How do we know that? Okay, a little louder.
There's significantly more in the
case.
not the control case. In the case, not the control. Sorry, I couldn't read that.
Yeah, so looking here at our cases, so this is just your standard bar chart. So we have frequency or number of cases exposed and number of controls. So we have 7 exposed cases versus 3, which is a lot higher in the cases. So when we look at these other ones, we have 6 versus 6 versus 6. 6 versus 5 and 5 versus 5. So they're all approximately equal prevalence of exposure among the cases under control. So we're going to say that PB pills is likely the cause of this cluster. Okay, so coming back to this group over here with our recommendations, now that we know it's PB pills, what are we going to recommend to the Department of Defense from stopping something like this happening in the future?
Education on the frequency of use.
Yeah. So we mentioned earlier that they may have been taking these pills too frequently because of the oversensitivity of the chemical alarms. So collecting information on that and education materials about that would be a good thing. What else?
If there is a suitable replacement, could implement that instead?
Yeah, so we can replace the exposure with something else that's maybe less toxic.
Maybe they could engineer a better chemical alarm.
Yeah, one that's not so sensitive. Yeah, exactly. Anything else? Okay, so I think we the one thing I want to bring up that wasn't brought up was we should be doing surveillance, right? So that we can identify cases from ALS occurring even earlier. And we should also maybe think about exposure surveillance so we know how many people are exposed to PB pills, how many people are exposed to permethrin or other things.
I actually have a question about that. Is this like the first time that they kind of used PB pills, or like they hadn't ever used them
No,
before?
so like I mentioned, it's a treatment for myasthenia gravis, and no one had ever used it in combat. And so they got a special waiver from the FDA to get approval so that they could use this during the Gulf. After the Gulf War, then they were no longer able to use it until 2003 when FDA again gave them a special waiver, or approved the use of it for combat only. The other unique thing about that with FDA though was that up until that time you had to have evidence from like 2 human studies to get a drug approved, and they came up with a new protocol where you could get it approved through animal research only, and this was the first drug approved through that new protocol. Okay, so now we've completed our mock investigation. So for the last 10 minutes or so, I'm going to talk to you about what's actually happened in response to this increased rate of ALS among veterans. So the VA did two things. First, they asked the Institute of Medicine, which is now called the National Academy of Medicine, to convene an expert review panel and to conduct a review of the literature and determine whether or not ALS was associated with military service, and then to make recommendations about future studies. So the conclusion of this report was that there was limited and suggestive evidence of an association between military service and later development of ALS. And then the recommendation was that future studies should be conducted to elucidate ALS risk factor development to military service. So the second thing that the VA did was that they established a registry, so now we're talking medical surveillance, established a registry where they tried to enroll every living case of ALS among veterans from 2003 to 2007. They ended up enrolling about 2,000 cases, including newly diagnosed cases as well as people who had the disease for a long time. And then they followed up these cases, mostly by telephone, every 6 months to see how their disease was progressing. They did also request new medical records for certain cases when they weren't quite sure if they had ALS or not. And the purpose of the registry was really twofold. One was to link cases with clinical trials so that they could be trying to give a treatment, because today there's only one FDA-approved drug and it only extends survival by 2 to 3 months. And the second thing was to foster epidemiologic research so we can try to figure out what causes it. So then researchers at Duke University in collaboration with the VA saw an opportunity to do a case control study. So the rest of this presentation is going to kind of follow the same outline that we've already gone through. So the study design they chose, as we talked about, was case control. They got about 630 ALS cases from the registry and about 1,000 frequency match controls from other VA databases. And the objectives of the study were to look for environmental and genetic risk factors for ALS and to look at gene-environment interaction, and also occupational factors. And one of the special focuses was military exposure. What were people exposed to when they were deployed to various wars? And how does that relate to ALS? So for our assessment of ALS, we went with medical record review because several cases had already passed away by the time the case control study started. It was only on average about 13 months after people enrolled in the registry that they enrolled in the case control study. But with ALS, that's not fast enough in a lot of cases. And this was also a national case control study, so it's kind of infeasible to send neurologists all over the U.S. For exposure assessment, for the reasons we talked about, the limitations of biomarkers and other things, we did structured telephone interviews and asked them about specific exposures. So I'm just going to show you a subset of our results. We actually looked at about 40 exposures, as well as things like branch of service and wars they were deployed to, how long they were deployed, etc. So I'm only going to show you a subset that seemed to be indicating some kind of a positive relationship with ALS. So oriented to the slide, I've listed the exposure here on the left, and we have the odds ratios. So the odds ratio of the diamond, 95% confidence intervals of the whiskers. So this is giving us kind of a reasonable range of values for what these odds ratios might be, and they go from the axis goes from 0.3 to 33, 0.33, because we have some pretty small sample sizes. So some of the exposures we were able to ask of everybody. Some of them are specific to certain wars, so our sample size decreases for those ones. Does anybody know what nasopharyngeal radium is or what it was used for? So this is an older exposure. Mostly it was used like in the 50s to treat sailors on submarines who had like otitis media and other ear infections. Personal pesticides for the more recent wars, this might have been permethrin like we talked about. For World War II, this was probably DDT, something like that, which is of course very toxic. High intensity radar waves is a form of non-ionizing radiation, so this is kind of like the radiation you would get from a power line. And burning agents are things like napalm, white phosphorus, thermite. There's even one called napalm B, which is benzene, which is a non-carcinogen. So looking at these, there seem to be some kind of indication. All of these have odds ratios of at least 1.5, and we have a couple that even reach statistical significance. We further looked, so most of our study were Vietnam War veterans, and this was really the only group of deployed veterans we had enough people to look at individually. We looked at a lot of the same exposures, but we specifically added Agent Orange. Does anybody know, because that was specific to Vietnam. Anybody know what that is? Or what it was used for? Yeah.
It's a herbicide. they use it to defoliate trees.
Yeah, exactly. So they're spraying this on the jungle so they can see who's hiding behind the jungle, basically. And all the rest of these are pretty similar to what I showed on the previous slide. So definitely a lot of indication that these chemicals might be positively associated with ALS. So to summarize, these kind of fall into 4 main groups of exposures. The first one, herbicides, pesticides, Agent Orange. So these are kind of our pesticide exposures. And looking at literature from non-military populations, there does seem to be some evidence, although conflicting, that pesticides might be related to ALS. Second group is more like solvents and chemicals, so same thing, looking at non-military populations, we see some evidence of a relationship there. And the third group is radiation. So most of the research there is on the non-ionizing radiation, so like extremely low frequency electromagnetic fields, your power lines, stuff like that. And then the last group, this is kind of our miscellaneous group, nearby explosions. You're not really going to look at that in a civilian population, or contaminated food. So certainly that needs to be replicated. So the recommendations that we made from this specific study was basically for more research, because this was the first study to have any kind of information on what people were exposed to in the Gulf. So I would like to continue to research on environmental occupational factors for ALS. So the Geneva study, this case control study that we have, has extensive occupational history data. We have information on the jobs that they held for at least 6 months, for every job from age of 16 onward. We've had industrial hygienists review that and assign a probability of exposure for like lead or other things. Also, I'm currently working at NIOSH. We have a lot of worker-specific cohorts that we can look at for neurologic mortality, like welders and nuclear workers are the 2 we've identified to work on next. And then there would be funding opportunities. ATSDR actually has a funding opportunity announcement that closes next week on environmental factors in the ALS. So if that's something that came out again in the future, that would be something I'd be interested in. More generally, we talked about the ALS registry, so they set up basically surveillance for that. They also set up surveillance for Gulf War illness for that kind of multi-symptom outcome. And they've started to do some exposure monitoring. So I have a colleague who works for the Army, and they've gone over to Afghanistan and put up like particulate matter monitors so they can try to get an idea of what PM exposures are. All right, so that is all that I've prepared. So does anybody have any questions? This is spraying Agent Orange and jungle.
Has there been ALS incidents in like the locals or like people living around those areas where there were any military areas?
You mean like in Iraq, for example? So I'm not aware of any studies that have looked at Iraq. The closest I've seen is in Israel. But I haven't seen if there's been any studies in Iraq. Certainly that would be an area.
Could you just go back one slide real fast?
Any other questions?
My question is, when you're not exposed, obviously, to person, like, how do other people develop ALS? I guess they're a known cause of.
So what's happening kind of at the cellular level is that it's kind of a problem with RNA processing, and you end up getting protein processing, and you kind of get these proteins that agglomerate, and then that kills the cell. And so there has been some like genetic research where they've identified associations there, but we're talking like really small numbers, 5% of people or something. But otherwise, this is an open question. Nobody really knows what causes ALS. I think one of the leading hypotheses right now is physical activity, actually. So Luke Gehrig, and there's been some other famous athletes who got ALS. You may have heard of Dwight Clark, I believe his name is, a tight end for the 49ers, just announced a few weeks ago that he has ALS. There are other NFL football players. And there's really, I think, 2 hypotheses about that. One is head injury, and then the second is physical activity. Studies there are pretty mixed. There have been some pretty interesting studies out of Europe and here in the U.S. One's finding no relationship with physical activity in ALS, and others are showing an inverse relationship, so it might be lower among people who are physically active. And then there was a really interesting study that came out of Sweden that looked at professional cross-country skiers, and they found that the skiers that won the most races, so the very best, had an increased rate of ALS. This is based on really small numbers, like 4 people or something like that. So caveat with that interpretation, but I think physical activity is really kind of the big hypothesis right now. One thing I didn't mention with Geneva, we've assigned applicational codes to everybody, and there are Java program matrices out there that we could link to those codes, so we can go through application of physical activity. Any other questions?
Folks, let's give Dr. Baird a hand. You should have an evaluation. We'd love to, Michelle, our guest, or one of the students out there reflect on something as you grab your sandwich, and thank you very much.